Good morning, everybody. Welcome to Sleep Medicine Grand Rounds. Delighted today to have Dr. Meena Khan from Ohio State University. She's an associate professor of clinical medicine, and she's the program director for the Sleep Medicine Fellowship program at OSU. She also serves as the co-director of the annual OSU Sleep Symposia, which I know many of us have at least participated in recently in terms of virtually. And she is also the director for their sleep medicine neuromodulation program for sleep disordered breathing, including both treatments for Remedy and Inspire. And just because of OSU's experience with Remedy and our own interest in getting started in this space, we thought we would have her come and talk a little bit about central sleep apnea and neuromodulation specifically in this setting. And it happens to align quite nicely because we have our first patient at UH that we're going to be activating today with this device. So Dr. Khan, welcome and thanks for presenting.
Yeah, thank you for having me. I'm happy to be here this morning. I hope you guys find this helpful. I'm going to share my screen here. Okay. Do you guys all see that okay and hear me okay?
Yes.
Okay. All right, great. So again, thank you so much for having me. My name is Meena Khan, and I've been with the Phrenic Nerve Stimulation program for almost 2 years. There were 2 other sleep medicine physicians before me who were with the program, and they left. So Dr. Rami Kayat started this program. He's very big in heart failure and sleep disordered breathing. He was part of the pivotal trial that led to the FDA approval for phrenic nerve stimulation. He left and went to a different institution. Then there was another sleep physician who managed the program, Dr. Maddie Rosenthal, for almost a year, and then she left, and so then now I've taken it over for almost 2 years. So I don't have any conflicts of interest. So hopefully by the end of the presentation, we can all describe the indication for phrenic nerve stimulation for central sleep apnea, understand a little bit about the mechanism of how phrenic nerve stimulation treats sleep disordered breathing, and then discuss a little bit about what's published in terms of effectiveness of the therapy. So just as a brief introduction, central sleep apnea, typically there's temporary disruption of the neural output from the brain to the respiratory muscles. And so it leads to pauses in breathing. And so what we see on sleep studies commonly, this black here, this is the flow channel, the blue are the effort channels, and then this is the oxygen saturation. So you see flow, and then an apnea here with cessation of flow, and then resumption of flow, and then there isn't any effort. And then just a key, again, I'm not sure, our fellows, we haven't delved into central sleep apnea yet in the curriculum. So for the fellows, for central apnea, when you see these we call them cardiac oscillations, that's pretty indicative that they have central apnea because they're not making effort, especially on the chest belt. It sits right on the chest over the heart and picks up the heart rate. And so when you see this, it's pretty indicative that it's true central apnea. And then this patient here has a little bit of crescendo, decrescendo, or chain Stokes. In terms of etiologies for central sleep apnea, congestive heart failure is one of the most common things we think of. 40% of these patients have central sleep apnea. Opiates can lead to central sleep apnea. Brainstem abnormalities such as CRE malformation can lead to central sleep apnea, and there are cases that are idiopathic. In terms of congestive heart failure, it affects about 1 to 2% of the general population. And there are those, as you know, with preserved ejection fraction, which is an EF greater than 50%, and then reduced ejection fraction less than 40%. And for those who have heart failure with a reduced ejection fraction, 25 to 40% of those can have periodic breathing in the form of chain Stokes respiration. So this is just an example of someone. This is actually a home sleep apnea test where we picked up the central apneas and the chain Stokes. You can see here there's the crescendo, decrescendo, and the central apnea. And with the chain Stokes respiration, when we look at the American Academy of Sleep Medicine, they have to have a cycle length of 40 seconds. So from beginning of the apnea to the end of the crescendo, decrescendo should be at least 40 seconds. So they have a longer cycle length. And so you have to have at least 3 consecutive central apneas or central hypopneas separated by the crescendo-decrescendo change with a cycle length of at least 40 seconds. And then the central apnea or central hypopnea index, which is the number of events per hour, has to be at least over 5 with this crescendo-decrescendo pattern. And then you could call this central sleep apnea with Cheyne-Stokes respiration. So when we look at heart failure and sleep disorder breathing, I mean, there are a lot of studies that show having obstructive sleep apnea and central sleep apnea can affect, or is associated, I should say, with negative outcomes. So for example, here, this is a graph, looking at the readmissions of heart failure patients in 6 months, and the blue are patients who have central sleep apnea, and the red are those who don't have any sleep disordered breathing. And you can see as the number of readmissions go up, the prevalence of those with central sleep apnea is higher. So in general, those who have central sleep apnea tend to have more readmissions for their heart failure. And this is another graph looking at central sleep apnea in red, obstructive sleep apnea in blue, and then no sleep disordered breathing. And this is patient survival. So this is patient survival here on the Y, and then on the X is going out over several months after discharge. And as you can see, those who have central sleep apnea and obstructive sleep apnea that are untreated, their survival tends to go down over time, whereas those who have sleep disordered breathing, while there is a trend to go down, there's a significant difference between those who don't have sleep disordered breathing and those that do. And so it is something we definitely want to look at treating in our patients due to this association. And then there are some studies that show results similar to this, where treatment of central sleep apnea and obstructive sleep apnea may affect post-discharge mortality. So again, here's patient survival on the Y, here's months post-discharge. These are the dotted lines here are central sleep apnea and obstructive sleep apnea that are not treated. These are central and sleep apnea, obstructive sleep apnea patients treated, and the black is no sleep disordered breathing. As you can see, there's a divergence in the curve here over time. Those who have untreated sleep disordered breathing, their survival goes down. Those who are treated, they tend to stay along the survival line of those who don't have sleep disordered breathing. And there's a significant difference between these groups. So when we look at, how do we treat central sleep apnea, optimizing heart function for those who have heart failure with a reduced ejection fraction is probably the number 1 thing we can do. If we can improve that, their central apnea at least is going to improve. PAP therapy is something we look at, and then we're going to talk about phrenic nerve stimulation. And just briefly about PAP therapy for central sleep apnea, there are some studies, a CAMPAP trial that showed with CPAP, there can be some improved oxygenation and left ventricular ejection fraction, and it did reduce the central apneas by about 50%. This study didn't really show much in terms of change in quality of life or transplant survival, or change in transplant-free survival or hospitalization. BiPAP, especially BiPAP without a backup rate, is going to aggravate central apneas, and so we wouldn't really want to use that in patients who have central sleep apnea. When adaptive servo-ventilation came out, this seemed to be a great option in terms of PAP for patients who had central sleep apnea. It treated their sleep disordered breathing well. There were studies that showed that there was associations with improved ejection fraction and quality of life. Comparing ASV to CPAP, ASV controlled their sleep disorder breathing more effectively, especially in terms of the central apneas. Adherence was better. And so adaptive servo-ventilation was really the way that we used to treat central sleep apnea patients, especially those who had heart failure. But then in 2015, the SERVE-HF trial came out where they looked at adaptive servo-ventilation in heart failure patients with an ejection fraction less than or equal to 45%. And they looked at that in those who had an AHI of greater than or equal to 15 with more than at least 50% or more central apneas. And they randomized those patients to treatment with ASV versus medical management. And unfortunately, what this trial found was that in terms of the primary endpoints, that the ASV group actually had a higher probability, which is the blue line here, compared to the control group. They had a higher probability of having cardiovascular events, death from any cause, and death from cardiovascular causes. And so since this point, it really, they're actually, FDA issued a black box warning, and, we're not really using ASV in patients who have heart failure with an ejection fraction less than or equal to 45% because of this trial. And so it left us with a bit of a conundrum of what to do. So phrenic nerve stimulation can be an option for these patients. It can be an option for anyone who has central sleep apnea. And we'll talk about the pivotal trial and the upcoming slides and what patients were included and what the results were. But in terms of what phrenic nerve stimulation is, so it's an implantable device. There's only one FDA approved device at this time, and it's called Remedy. So if you hear me say Remedy or Zoll, it's just because that's the only FDA implanted device at this time. So basically, there's an implanted device. This is done by interventional cardiology through a catheterization procedure where they put the device in, and then the sense lead, which senses whether or not the patient is breathing, is actually within the generator. And then there's a stimulation lead that's snaked through one of the veins near the phrenic nerve. So either the brachiocephalic vein or the pericardiophrenic vein. You need a vein that is by the phrenic nerve because it stimulates the phrenic nerve through the vein. You do have to have a phrenic nerve that is conducting. So if somebody has a neuropathic condition where their phrenic nerve is not functioning, they cannot get this device. There has to be conduction through the phrenic nerve for this device to work. And it will stimulate the hemidiaphragm. And then when it stimulates the hemidiaphragm, actually both sides will engage for breathing. And this is just an X-ray of a patient who has the device in place. And so you can see the generator here. You don't really, here's the, I don't know if you guys can see it there, but you can see the stim lead here that's snaked through the vein. So this device, I don't know if you guys are familiar with Inspire. Inspire is an upper airway stimulator device treated for obstructive sleep apnea that the patient turns on with a remote. So this operates, the phrenic nerve stimulator operates differently. It comes on automatically. So there are three things that have to be in place. It has to be a scheduled time when the patient is asleep. The patient has to be in a reclined position. So there's position sensors in the device that can tell what we call pitch. And so we set what pitch the patient needs to be below for the device to turn on, and they have to be not moving. So when all these three things are in place, the device will turn on. In the middle of the night, the patient can pause therapy if they sit up. So when they sit up, the device automatically pauses. You can program this time. Most of the time we program it for 10 to 15 minutes, but the range you can program is anywhere from 1 to 30. When that time frame is up, it will reassess for all three things again. So is it after the time that they're supposed to be asleep? Are they reclined? Are they not moving? And if all three are met, they'll resume. If the patient moves side to side, it will pause. We usually make this briefer, like around 2 or 3 minutes, and then it reassesses for all three criteria. And if the patient meets all three criteria, it will resume therapy. And then it turns off at a certain time in the morning that's preset into the device. So this is a schematic just to kind of show how the therapy works. So what is programmed into the therapy, and we'll go into more details in the upcoming slides, but is a target breath rate, which is usually the patient's wake breath rate -2. And that's programmed into the device. And then there's a range of strength, which is measured in milliamps, that's programmed into the device. And we'll talk about how you get to those numbers in the upcoming slides. But you program the rate, the target rate, and you program the milliamp range. Let's say 3.5 to 4.5. I'm just throwing that out there. So when the patient sleeps at night and it's time for therapy to turn on and it turns on, it will analyze the breathing. So here you see the Cheyne-Stokes, the central apneas, and therapy is off.
Wow. The face coming back today. Is she? Really? I mean, she did amazing.
Yeah, if everybody could just make sure that they're muted, that would be appreciated. Thank you.
I think I did that pretty good. I mean, I wasn't like flustered or anything. It was, we were busy back, but most of it
Wanda, I don't think you can hear me, but if you
there
do,
were a few things
just
that
need to mute
we
your
got
line.
stuck on. I got stuck on it. She helped me through that. But yeah, and I had Lauren and Aaron and
Have
Abby.
the host
But not you.
function yet, Meena.
maybe-
Eric, I don't know if you do.
not find. I'll have to see how you did.
So basically what
I
you
didn't
do
find
is
it.
the therapy will sense
Like,
that the
I
patient's
couldn't check
having
it,
central
but
apneas,
I was
and they will
like,
start it will start increasing the milliamplitude until it what we call captures.
And that worked well.
Capture the breath rate here. So you can see here how the breath rates are starting. And that will keep increasing it until it becomes more uniform. And then once it becomes uniform, it will continue on with that rate. And then you can see the therapy turns off, the central apneas resume.
So I wouldn't get backlogged on anybody, but
Okay.
took all kinds of payments. So I was happy about that. It wasn't like I had to go out to Rev Cycle and all that other crap.
The FDA indication for phrenic nerve stimulation is moderate to severe central sleep apnea. There is no qualifier for obstruction.
Like I kept forgetting because it wasn't like that hard stop was the sign of consent.
Excuse me, do you know you're not muted?
So, you know, first day and the first after that it seemed to
Wanda?
be that and
Wanda, you're not muted. Okay, there we go. All right. So the FDA indication for phrenic nerve stimulation is moderate to severe central sleep apnea. There is no qualifier for obstructive apnea. So they don't have to have, even though in the pivotal trial, which we'll go through in a little bit, they excluded patients who had more than 20% obstruction. That's not part of the FDA indication. So if you have patients who have more than 20% obstruction, they may have residual obstructive apnea that's significant, that may need to be dealt with. And so it's important they know that. So they're prepared for that, if they decide to go through with phrenic nerve stimulation. The device is MRI compatible. It recently got the FDA approval for MRI compatibility. So there is no issue with that right now. So this is the phrenic nerve stimulation patient care pathway. So once a patient is implanted, a month later, they're activated. During that time between implant and activation, the device is acquiring data on the patient's sleeping position and activity that can help in the activation visit. Then 1 month after the implant, the patient is activated. And during that visit, we put in the times that therapy is turned on and turned off. We set the pitch. So what's the angle the patient has to be below for it to kick in, and then the amplitude range. And then we'll talk about that in the next slide. So in terms of the time on and off, we can look at the activity that the device has acquired in the previous month of when they seem to be less active versus more active, and then their sleeping positions when they seem to be reclined versus upright. And then talk to the patient about their schedule, their sleep schedule, and make sure everything kind of lines up to set the on and off time. Then the device automatically increases the amplitude in weekly increments for 6 weeks. So the range that you put in, the milliamp range that you put in, it increases this range every week for 6 weeks. And then the patient is seen in a follow-up visit to look at the programming data and make adjustments. And we'll go into more detail about what all this means again in the upcoming slides. Usually there's about 3 to 4 visits. And then when you look at the programming data, you can see what's the rate of capture, like at what milliamp it seems they're getting capture of the respiratory rate. Are they tolerating the therapy? There are waveform browsers that you can look at to get an idea of how many events they're having. And then when it looks like things are pretty teed up, then they'll go for a sleep study. Ideally, they come for an in-lab. In our center, we have a lot of patients that come from 1 or 2 hours away. They don't want to come to the lab, but they're open to a home study. And so we do some home studies in these patients, because if we don't do that, we won't have anything. And you can score central apneas. And so typically what we'll do is, if we're seeing a lot of central apneas on the home study, we'll make a few adjustments, but then we'll say you're going to have to come for an in-lab for the next one. So we make sure that we're looking at the right thing when we're adjusting your device. Once they're stable on therapy, we see them every 6 to 9 months, mainly to monitor their battery life. So as opposed to the Inspire device, where it's basically like every 10 years or so you change the battery. With this device, it depends on how much energy they're using. If they're on the higher end of the milliamp range, they'll go through the battery faster than if they're on the lower end. And so we monitor the battery life at the follow-ups, and when we see it starting to go down, we'll schedule them for a change out. So in our institution, the device is implanted by cardiology, and we co-manage the device with cardiology. So they implant the device. They have a cardiology nurse practitioner who's worked with devices for several years. So she was excited to be part of this program. So she actually does the activation and the initial appointments. And then once she feels the therapy is optimized, we see the patients together in a combined clinic, myself and the cardiology nurse practitioner. And we look at the data together, and then I kind of say, yeah, we'll do the sleep study. I read the sleep study. I let the patient know the results. If there's residual obstruction, then I talk to the patient about it, and I manage that part of it. And then after that, we co-manage the patient in this combined clinic. So this is just an example of what you can see on the programmer. So this is data you can get this data at any time, but in particular, when you're from implant to activation, you can see what's their pitch and their activity. So this is an example of pitch. The gray is when therapy would be on, the clear is when it would be off. This red line is the pitch that is set into the device. And so when they're below this, the therapy will turn on, and when they go above it, it's going to turn off. And so you can see what times this tends to happen, and then link it up with what the patient says when they fall asleep and wake up, so that you make sure that you're pretty accurate with when you're having the therapy come on and off. And then you can actually see activity trends of, when they tend to be active. And then here's an example of an activity trend in just like in a day over the times. And again, you can make sure it's syncing up with their times in bed, out of bed, and their pitch and their activity, just to make sure you're getting within the range of time for therapy to come on and off. So in that activation appointment, everything is done with a programmer. So this is the programmer. This is the connector here. It connects to the programmer. And so you put that on the patient's chest where the device is, and use the programmer to make the changes. So again, on the activation appointment, your program breath rate is, the goal breath rate is the breath rate when they're awake -2. And then in terms of when you turn the therapy on and off, you want to make it a time that the patient thinks that they fall asleep, and you can set a delay. So let's say they go to bed at 11. You can then also set a 30-minute delay that gives them time to fall asleep. So that way they're getting into bed at 11, but if they don't fall asleep to 11:30, therapy doesn't kick on until that time. You program a time where therapy stops in the morning, and then you program the amount of pause time if they sit up or move around. So again, when they sit up, it can be anywhere from 1 to 30 minutes, but generally we make this 10 to 15 minutes. And the pause, if they turn side to side, we usually make around 2 minutes. The other thing we program is the amplitude, which is in milliamps. So we determine the range of this, and you determine this for different sleeping positions. So you have a different range for supine, right, left, and prone positions, because their need for treating their sleep disorder breathing may be different in position to position. So how you start out is a minimum amplitude of this range is going to be what's comfortable for them while they're awake in the office. And again, you test this in all 4 positions. And then the max is what's uncomfortable while they're awake in the office. And that's how you set the range. And then the device is going to start with that range, and every week slowly increase it. And the goal is that at the end of 6 weeks, that range is going to go up by 20%. And then when you see the patient in the office, you're going to look at their data, see like what's their rate of capture? Are they capturing most of the time? What milliamp is that? How is the patient tolerating it? And then you'll make adjustments in the range based on that. So during the 6 weeks between the visits, again, the device is analyzing the breath every minute, and it increases the milliamplitude until that program breath rate is met. And that's what we call capture. And then the min and max range is going to increase weekly to a goal of 20% of what was initially programmed. And then at the 6-week appointment, we look at the program data and decide, if this milliamp range needs to be changed. If the patient's not doing well titrating at home, or you feel like there's somebody that's going to have difficulty tolerating therapy, You can titrate patients in the lab. The majority of the patients are titrated at home, but we've had a couple where they're titrated in the lab. And typically what we do is bring in a representative from the company, and they come to the lab and they will adjust the settings in the lab while the patient is sleeping. So you can do that initially, or you can do that if you've done your best to try to titrate them as an outpatient and they're having difficulty tolerating therapy, or you're not getting good results on your study and you're not sure why. You can bring them in and they can help you out with an in-lab titration. So at follow-up appointments, the things we look at in the programmer is, again, the pitch. Is therapy coming on and off at times that seems to coexist with what the patient says they go to sleep and wake up at? You can look at their activity trends again, and make sure that their activity trends are following what you've had for therapy on and off. And then you can look at their capture. So you can see here, this is the green is good capture, orange is like medium capture, and red is low capture. And then these are the milliamps. And so you can kind of see here, this patient is getting good capture around 0.9. And let's just say, I'm throwing it out there, their range is 0.2 to, 1.8 or something like that. And they're tolerating therapy, they're doing well, it's not waking up, they're getting good capture at 0.9. You may then adjust their range to, 0.6 to 1.6 or something like that, and adjust their range that way. And then bring them back and see what their data looks like, see what they're saying, how they're feeling. And you can get this capture rate. You can get a picture overall for the whole night. You can get a picture over a 3-week average. And then you can also get a picture by position. So you can see here, this is the supine position. You can see here, this is the left side. And it may be that they get capture at different milliamplitudes in the different positions. And so you would have different ranges for all four positions. So at the sleep study, again, this is generally done after 3 or 4 visits with the therapy. You can, again, in-lab is ideal. If we can get an in-lab, we will get an in-lab. However, again, we have patients who will say, well, do I really have to come to the lab? I don't think I'm going to sleep in the lab. It's a 2-hour drive. And so we will do home studies on some of those patients if they prefer, because we want to have something. We don't want to have no testing at all. If we see continued centrals, we further titrate the settings and then retest. If they're controlled, then that's great. If there's residual obstruction, which we have seen in a handful of patients, we discuss it with the patient. Based on what severity is, we discuss the treatment options. So if they're mild and they're not symptomatic and they're not really open to trying PAP or an oral appliance, we'll discuss with them weight loss. If there's a positional nature to it, we'll discuss positional therapy, and we'll follow them clinically. If they're moderate to severe, we really try to get them to use something for it. So we have one patient with an oral appliance. So we have a patient with CPAP and this device. And we have a few that are not doing anything. I just saw one yesterday who his centrals are controlled with phrenic nerve stimulation, but he has a residual obstructive component with an AHI of 30. And he doesn't want to, he's tried CPAP and he's tried an oral appliance. He doesn't want to go back and try those again. So he is someone, there are a few cases of clinically of patients being implanted with the phrenic nerve as well as the upper airway stimulator. And so I'm going to talk to some team members about that. I mean, he is severe and he's actually gained a bit of weight since that last study. So like at least have the discussion about whether or not this is something we should think about for him. And there are patients that are open to having both devices, but there's just a few, and I don't think any of the case reports are published. I think this is all the company has told me. There's some clinically, but I don't know that anything is published on it. So, and then once therapy is stable, again, we see them every 6 to 9 months in order to monitor their symptoms and their usage and their battery life. So at these, what we call maintenance follow-up visits, we look at their battery status, their therapy duration, their capture, and then we can look at some waveforms. So this is an example of the battery status. So this patient, they're in good status. When it starts going into the orange, then we have to monitor it more frequently. So maybe we'll see them back every 2 to 3 months. And then when it starts getting to the red, we schedule them for a battery change out. The other thing we can see is therapy duration. So how long are they having the therapy on each night? And so these P's are called pitch violations. So if someone has 1, 2, 3 pitch violations on average a night, that's okay. But if they're having several pitch violations, 5, 6, 7, then we'll talk to them, is it the therapy? Is the therapy waking up? You feel like you have to pause it a lot, and they may need to have their range decreased. If it's not the therapy and it's other things, that's fine. But we just that cues us to ask them about it if the therapy is bothering them. And then this is the capture. Again, you can get this night to night. You can get this on a 3-week average. And you just want to see, are they getting good capture most of the night? And then you can see at what milli-amplitude they're getting good capture, and just see where that falls in with the range you've set, and if that range needs adjusted or not. And of course, is the patient tolerating it? So there are some patients, they're getting good capture at, 3 milliamps, but they're like, I can't. If you start me out at, 2.8, I can't tolerate that. So we have to start them at maybe 2 or 2.5. and let them slowly get up to the 3. And so they may have more time where they're not treated because of that. So you do have to match the capture with what the patient can tolerate, because they don't always coincide. And then you can look at waveforms. Now, these are not exact or ideal, but they give you some idea. So the device can store about a minute of respiratory snapshots every 15 minutes. And you can filter these. So you can look at an average, you can look at different milliamps, you can look at the different positions, and then you get these little snapshots. So you just click on each of these and it'll give you a snapshot of what the waveform looks like. And then you can see, like, this looks like it's a pretty well synchronized waveform here. You don't see a lot of decreases in flow or issues with the waveforms. And then this is maybe this is essential apnea. They have definitely a decrease in the flow, and it has these rapid oscillations. Maybe those are cardiac oscillations. And so this may key, like, maybe we need to adjust the therapy, or if we're adjusting the therapy and this isn't getting better, they probably need a sleep study so we can see what's going on. This might be a hypopnea. You see a decrease in flow. But you don't really see the cardiac oscillations. And especially if someone has a lot of residual obstructive that we saw in their sleep study, this could be it. So, I mean, it can be helpful to guide therapy. It can also be, if you're not sure what you're looking at, can be confusing. So, for example, the patient I described yesterday, who had a lot of residual obstructive, his sleep study showed his central was resolved. He was showing a lot of low flows that the cardiology nurse practitioner I work with was showing me. And I said, I think this is probably his obstruction. I don't think we need to adjust his phrenic nerve stimulation for these events. And so it's important to have a partnership with someone who knows how to manage the device, but also understands the sleep medicine side of it. So now this is the pivotal trial that led to FDA approval. So this was a multi-center randomized controlled trial of central sleep apnea. So they started with 151 patients, 96 of these were heart failure patients, and they randomized them to treatment versus control. So to be in the trial, the patients had to be medically stable for 30 days prior to entry. They had to have an apnea-hypopnea index of at least 20. They had to have at least 50% of the apneas be central apneas, and at least 30 central sleep apnea events total over the entire study. The obstructive apnea index had to be less than or equal to 20% or lower of the total AHI. And the hypopneas in this study were not designated as central or obstructive. So 73 were assigned to treatment, 78 were assigned to control. So again, treatment was a phrenic nerve stimulation, control was typical medical management. And they ended up at the end of the study, after all the exclusions, 58 in the treatment arm at 6 months and 73 in the control arm. And what they found was there were significant, looking at the heart failure versus non-heart failure, and of note, they didn't have any opiate-induced central apnea in this study. Those patients were excluded from this trial. So in the heart failure patients, 63% of them, which was 22 out of 35 in the treatment population, had an AHI reduction of at least 50%. There also were 2 heart failure in the control group who had an over 50% reduction. And then 64%, which was 26 out of the 35, had a treatment AHI less than 20. And then non-heart failure patients, 57% of that group, which was 13 out of 23, had an AHI reduction of at least 50% or more. And then 6 out of 28 in the control group. And then if you look at the study overall here, if you look at things like the oxygen desaturation index at treatment versus control here at baseline, and then if you look at the 6 month here, there is a significant reduction in the treatment group for the oxygen desaturation index. So you can see here it says Meena 43.8, and then treatment was 24.7 with a meaningful reduction. And the Epworth sleepiness scale had a meaningful improvement. So at baseline, the treatment group had an Epworth of 10, and then at 6 months, it reduced to 7. The control group had a 9, and it stayed pretty much at 9 at 6 months. This is a graph just to show the difference in treatment. So this was in the treatment group, this is in the control group. The red is an increase in AHI and a green is the decrease. So you can see there's a significant number of decreases in AHI, and in the control group, significantly more increases with some decreases in the control group. And then when you look at how patients felt about therapy, this is the treatment group, and then this is the control group. So the majority of the patients felt markedly to moderately improved with therapy, with some mildly improved. There was 14% that didn't feel any change, and about 6% felt they were worse. When you compared that to the control group, there was a minority of people who felt markedly to moderately improved. The majority felt no change. And then there was about 25% that felt worse. So again, subjectively, those who were with the phrenic nerve stimulation felt much better with therapy. So this was data at 6 months. This is what led to FDA approval. They did take the heart failure patients. So the treatment group stayed on therapy, and then the control group was started on therapy. And at 1 year, they looked in particular the heart failure patients, and there were 96 of those patients. And at 12 months, they had about 75 that completed their visits. And they found that they continued to have a significant reduction of central apnea and improvement in quality of life. So here's the central apnea index at baseline. At 6 months, it was reduced to about 4, and then at 12 months, it's about 3.5. So again, significant reduction in central apnea. If you look at overall AHI, there was a significant reduction, 47.1 at 6 months to 25.2, and then about 25 at 12 months. So clearly, there is a reduction, but the reduction is in the central apneas. They don't have the obstructive numbers here, but if you look at this graphic where they look at these patients and they follow them out to 5 years, the orange is the central apnea, the blue is the obstructive apnea, and the sea green is the hypopnea. And you can see over time, the central apnea is really what reduces. The hypopneas didn't really change, and the obstructive apneas didn't change, which we would expect them to. And so really the reduction in AHI is in the central apnea, and that's maintained out to 5 years. Outside of the pivotal trial, there's not a lot of other studies. There are some small studies, and then I found this systemic review looking at the phrenic nerve stimulation for central sleep apnea, although a lot of the data for this meta-analysis comes from the pivotal trial data. But they did find that in general, they found a significant decrease in the central apnea index and a mild to marked improvement in quality of life based on patient questionnaires. So then I was going to just show you a few cases of some patients that we've had here at Ohio State. So this is a 71-year-old male with severe sleep apnea. He was diagnosed in 2019. He had an AHI of 57.6. And the breakdown was 1 obstructive apnea, 2 mixed apneas, 121 central apneas, and 81 hypopneas. And we didn't distinguish hypopneas as obstructive or central. So if you look at the obstructive index, which was OAs and MAs, it was 0.85. Central apnea index was 34, and then hypopnea index was 22.8. So he went for implant. He was implanted in 2020, and he did well after implant. He was very happy with his therapy. So we decided to do a home study 1 year after implant. And when you looked at that, the overall respiratory event index was 26.9, with 36 obstructive apneas, no mixed apneas, no central apneas, and 153 hypopneas. So his central apnea resolved. And I would say, anecdotally speaking, this is what we see with phrenic nerve. It does really great job getting rid of central apneas, but it obviously isn't going to change the obstructive. And sometimes once the centrals are gone, we see more obstructive on their study. It kind of unmasks it, I guess, in a way. And this is what we saw on the home study. So these were the hypopneas that the patient was having. So these, look obstructive. And when you look at the breakdown of it, it was mostly positional. So, when he was supine, his respiratory event index was 45, and when he wasn't, it was 6.4. So we discussed with him all the treatment options. This patient was a little upset. So he started with the program before I joined. And then when I joined him, that's when we did this 1-year home study. So he was a little upset about his residual obstructive because he was told he really didn't have much obstructive before, and he didn't understand why the study was showing something different. We actually did 2 studies just to kind of show him that of what was, this is a true, like you truly do have obstruction. So he wanted to do an in-lab. So we did do an in-lab a few months later, and we had talked to him about positional therapy because it definitely seems like it's more prominent on his back. So he trained himself to sleep on his side, and that's how he did the in-lab. And his AHI was about 4.3. So he just does positional therapy with his phrenic nerve stimulator, and he's very happy doing that, and he's happy with therapy, and he feels good. So this is the second case. This is a 69-year-old male with moderate sleep apnea, has a history of heart failure, hypertension, and anemia. So his diagnostic study was in 2020, and his AHI was 24.7, with mainly central apneas, not really many obstructive or mixed, and 42 hypopneas. And it was also noted that he had Cheyne-Stokes respiration with cycle lengths of 43 seconds. So he was started on CPAP just to see what would happen, but he had continued centrals. And again, this was before I started, so I don't know if he tried bilevel or because of his heart failure, they didn't even bother trying bilevel. I'm not sure, but he was on CPAP, and then he was referred for phrenic nerve implant. And so he did get the implant. And then when he had a sleep study with the phrenic nerve stimulation he had an overall AHI of 19.4. And it was mainly obstructive. So he had 21 obstructive apneas, 94 hypopneas. He only had 2 central apneas, and that should be MA, no mixed apneas. So again, the obstruction seemed to come out a little more once his central was controlled. So he decided he was going to continue with his CPAP and use phrenic nerve stimulation. So at a follow-up appointment, and this is where I started seeing the patient, is at this appointment, he said he was using CPAP with his phrenic nerve stimulation, and he felt he was doing fine, but his programmer was showing a lot of respiratory events. And we didn't have the download at that time, his CPAP download, but he said he's using his CPAP without issue. He uses it every night, and he's doing fine. And so the cardiology nurse practitioner I work with was like, should I adjust the settings? Could these be centrals? So I said, well, let's just get the CPAP download and make sure he's using it, and all of that looks okay first. So we were able to get a download, and he was on a fixed pressure of 8, and his use is pretty good. He uses it over 4 hours for 89% of the time. His average use is 6.5 hours. And if you look at the therapy data, he has a residual AHI of 22, and the central index is 0.8. So it's mostly the obstructive apneas, and he's not having much leak. He's not complaining of leak. So I changed his device to auto mode. So he had an auto machine, but it was fixed. He had ear popping in the past, and so they fixed it at a low pressure because he had this ear popping. So I said, well, let's just give you a little bit of range of 8 to 12. And when he came for his follow-up, his residual AHI was better. It was down to 6.8. Again, he wasn't having any centrals on the breakdown. He wasn't having the ear popping. And he's been doing well with CPAP and the phrenic nerve stimulation together. So again, this is, we saw events on the browser that were things that signaled us we need to look further, but we didn't want to jump to just adjusting the therapy. Since he has a mixed picture, you want to know what you're adjusting, because you don't want to be increasing the milliamps for centrals when the problem's really obstructive. So this next case, this is this 65-year-old male with myotonic dystrophy. He was diagnosed with moderate obstructive sleep apnea. In his sleep study, he had a few obstructive and mixed apneas, 53 central apneas, and he had hypoventilation with the TCO2 monitoring. So he tried IVAPs, but he didn't tolerate. He was sent for implant, which he got in 2019. And then the repeat study showed an AHI of 10.9, so it did improve. But he did still have residual central apneas on that study. So the phrenic nerve therapy was adjusted further. And so even after adjustment, it was showing persistent events. So we said we should repeat the study and see what's going on. He didn't want to come to the lab. We had this long discussion. So we ended up doing a home study, and it showed an AHI of 20.7, and it showed mostly obstruction with just a few central apneas. And so we discussed again with him, PAP therapy for him. He has myotonic dystrophy. I felt like PAP therapy would be better. But I did say, you know, we could do an oral appliance, although I'm not sure that's really going to treat everything, but he declined all of that. So he's using his phrenic nerve stimulator well, and we're just kind of discussing the obstructive part at every follow-up just to revisit it with him. And then this is the last case. So this is a 74-year-old female. She has multiple cardiac issues. She has a pacemaker. She has COPD. She has heart failure. She did not tolerate PAP. Because of all her cardiac issues, we did a diagnostic study before we would go forth with implants. So we repeated her diagnostic study, which was done in February, and it showed an AHI of 59, which majority centrals, and she had Cheyne-Stokes respiration. So she went for implants. And this is the diagnostic study. So this is the hypnogram, and the blue here are the central apneas. So she did have some hypopneas, particularly during REM, but the majority of her events were central apneas. And you can even see here with the oxygen saturation signal here, this is kind of consistent with central apnea too. And then this is what the flow looked like. So it clearly looks like central apnea with some Cheyne-Stokes respiration here. So she was someone who got titrated in the lab just because she had a lot of anxiety issues and things like that. And so we had the representative from the manufacturer come in and do a titration with her in the lab. And so they went up on the amplitude range in the lab. And so what we saw was this, which we weren't expecting, is she started having obstructive apnea. So at the lower range was 1.5 to 2.3. She was having all this obstruction. Then there was a period where it went away, and then it came back. So if you look at how they had programmed the range, when they went up on the range from 2 to 3, it got better, but then when they went down, it came back. But if you look at they had also tagged the milliamps that what the programmer was reading for that time. It was reading 2.7 here when there wasn't any events, and 2.7 when there were. But the thing that was different is that her head was to the side. So she was sleeping on her back. She sleeps on her back all the time. She slept on her back for that diagnostic study too, prior to implant. And she had her head, when she had her head to the side, like her head would be like this, she wasn't having anything. But when her head was straight like this on the pillow, that's when she had the events. I didn't really know what to make of that. This is the titration. So these were the events here. So they look, I showed this to a few different colleagues. I mean, they are long events, but they do look obstructive. So when she followed up, she was tolerating therapy. She was feeling great on therapy. She says she sleeps with her dentures in. She had some sort of viral infection when she was in her late teens, early 20s, and she lost all her teeth. And she's worn dentures ever since. And because she was young, she's like, I'm not going to sleep without teeth. So she would sleep with her dentures. That's how she's always been. That's how she always does it. That was the only thing that was kind of off with, her sleeping, like her sleeping structure. So I don't know. I don't really know that with the head position, obviously if her head is straight, I guess it is possible things are falling back. And the prior study, it's archived. I can't get the video because they don't keep the videos in archive because it takes up too much memory. So I can't see what her head position looked like in the diagnostic. But what we did was we just changed the programming range while she was supine to the higher range, and we're going to do a home study. And I was hoping I would have this home study for this presentation, but she has rescheduled it a couple of times and I don't have it yet. But we're just going to see what happens with this home study and then kind of go from there. But she's tolerating it and she's doing well. And then this is just an example how you'll have different ranges for different positions. So she mainly sleeps on her back. And that was when we saw those events. So she's on a higher range and she's on lower ranges on her side. And when she's prone, and she rarely sleeps on her side or prone anyway. So in conclusion, phrenic nerve stimulation is FDA approved for moderate to severe central sleep apnea. There are no caveats for obstruction, but you do want to be aware if your patient has more than 20% obstruction, there probably will be residual OSA, and it might even be more prominent once the central apneas are gone. Generally, you'll see over a 60% reduction in AHI, and mainly this is a reduction in central apnea and improved sleepiness. So that's what you see in the literature. And I'll say anecdotally, I feel like this therapy does really well for central apnea and people like it and they feel better. The problem is the residual obstruction and how to handle it and just making sure the patient knows that ahead of time. And then also making sure you have a good baseline. I would have a recent baseline before implant. We've had a couple patients that are part of what's called the REST trial. So the REST trial is the registry for phrenic nerve stimulation for clinically implanted patients. And if they're in that trial, part of that trial is they get an in-lab sleep study right before. So they're implanted and then get an in-lab sleep study right before activation. So they have their baseline that qualifies them for implant, but they do another one before activation. And there have been a couple that on that study, they don't have central apnea. And those are typically patients that have come to us from another group. And I don't know, maybe something changed in between. I don't know, what happened for the change in the study. But patients are reluctant to have it done. Like, I just had this done last year. Do I really have to have it done again? Nothing is different. My weight is the same. And so you're like, okay, sure. And they'll implant them. And then we get those couple times where they don't have apnea on their diagnostic. So we've kind of changed to, we want to have a study here that we can look at so we know what we're doing before we implant you to make sure we're not implanting a device for someone who may not need it. So, all right, well, thank you.